There is something happening right now that most people over 60 have not been told, and I want to be very clear with you from the start. This is not a panic piece, this is not sensationalism. What I am about to share with you is grounded in science, and it is information I believe every older adult deserves to have, presented honestly and without the noise. The World Health Organization has issued a global health emergency in response to a resurgence of Ebola, specifically the Sudan strain, in regions that were not previously considered high-risk zones. And here is the part that most public health messaging quietly glosses over. The data from previous outbreaks consistently shows that adults over the age of 60 face a significantly different and more serious disease course than younger populations. Yet almost none of the public guidance you see is written with you specifically in mind. That gap is exactly what I want to close today. Before we go any further, I want to tell you about a woman named Margaret. She is 71 years old, a retired school teacher living in a mid-sized town in rural Uganda. She lost a neighbor to the virus during the 2022 Sudan strain outbreak, and she herself was later admitted to an isolation facility after testing positive. Her doctors were cautious. Her family was terrified, but Margaret survived. And what her medical team documented about her case, compared to others in that same facility, is something we will come back to later in this video because it contains a lesson that may genuinely matter to your health, regardless of where you live or how far away an outbreak feels right now. Before we get to that, I want to ask you something. Drop a comment below and tell me, how old are you? And have you or someone close to you ever lived through a serious viral outbreak, whether that was COVID, H1N1, or anything else? I genuinely read every comment on this channel, and your experiences help shape what I cover next. Now, let us start with the biology, because understanding what Ebola actually is separates real knowledge from the kind of background fear that never does anyone any good. Ebola is a member of a virus family called Filoviridae. The name comes from the Latin word for thread, and if you have ever seen electron microscope imagery of this virus, that name makes immediate sense. It does not look like the round sphere most people picture when they think of a virus. It looks like a long, twisted filament, sometimes curled in on itself, sometimes stretched to remarkable lengths. It is, in the bluntest possible terms, unlike almost anything else we study in virology. The virus was first identified in 1976 during simultaneous outbreaks in two separate African nations, one near the Ebola River in what was then Zaire, now the Democratic Republic of Congo, and one in Sudan. Two countries, same virus, same year, neither outbreak connected to the other. That alone told researchers early on that this pathogen had been present in the environment far longer than anyone had realized. 6 distinct species of Ebola exist today. The one responsible for the most deaths, the most documented outbreaks, and the most studied clinical course is simply called Ebola virus, previously designated the Zaire strain. This is the strain behind the catastrophic West African epidemic that unfolded between 2014 and 2016, which infected more than 28,000 people and killed over 11,000. That single outbreak claimed more lives than every prior Ebola event in recorded history combined. And it happened in a world with international response teams, satellite communications, and billions of dollars in emergency resources deployed to stop it. The current emergency involves the Sudan strain, different surface protein structure, different behavior, and crucially, no approved vaccine currently exists for it. There is a vaccine called Ervebo that was developed following the West African epidemic and has been successfully used in Zaire strain outbreaks since, but the Sudan strain does not respond to that vaccine. Candidate vaccines are in accelerated trials, but as of right now, none have received full regulatory approval for large-scale deployment. That matters, and I will explain exactly why it matters specifically to you in just a moment. But first, let us talk about how this virus actually spreads, because there is a tremendous amount of confusion on this point, and confusion in an outbreak context can genuinely cost lives. Ebola is not airborne. I want to say that plainly because fear has a habit of filling the gaps that accurate information leaves open. You cannot contract Ebola by being in the same room as an infected person. You cannot catch it through shared air, a ventilation system, or a crowded space. This is fundamentally different from influenza or COVID-19, and it is the reason that, despite its terrifying mortality rate, Ebola outbreaks have historically been containable when the response is rapid and well resourced. What Ebola does require is direct physical contact with the bodily fluids of a person who is both infected and symptomatic. Blood, saliva, vomit, sweat, urine, and other fluids, if any of these come into contact with your eyes, nose, mouth, or broken skin, transmission is possible. This is why the highest risk groups during outbreaks are consistently healthcare workers, the family members who provide home care, and communities where traditional burial practices involve washing or touching the body of someone who has died. That last point carries enormous weight. In many communities affected by past outbreaks, the act of preparing a loved one's body for burial is not merely cultural, it is a deeply sacred expression of grief and respect. Asking families to forgo that final connection is not a clinical recommendation. It is a request that comes with real emotional cost. It is one of the most difficult dimensions of outbreak response, and one that rarely gets the acknowledgement it deserves. The natural host of Ebola, the animal in which the virus lives without causing the kind of catastrophic disease it causes in humans, is believed to be a group of fruit bats from the Pteropodidae family. Spillover from animals to humans typically occurs through direct contact with infected animals or their meat. This includes bats, chimpanzees, gorillas, and several other species. Researchers have documented that these spillover events appear to be occurring with greater frequency as forest clearing brings human settlements into closer contact with wildlife habitats. Ebola can also survive outside a living host for several hours on dry surfaces and longer in wet environments. This is why protective equipment is not optional for anyone providing care during an active outbreak. It is the physical barrier between a manageable risk and a catastrophic one. Now, I want to walk you through what actually happens inside the body of someone who contracts this virus, because this is where the science becomes both extraordinary and, for older adults especially, deeply relevant. Following exposure, Ebola enters what is called an incubation period, the time between when the virus enters the body and when symptoms first appear. That window ranges from 2 to 21 days, with most people developing symptoms somewhere between 8 and 10 days after exposure. During this entire period, the infected person is not contagious. They feel fine, they have no symptoms, and they can be anywhere in the world. This is one of the factors that makes Ebola such a complex public health challenge in our era of global travel. A person exposed in an outbreak zone can board a flight, land thousands of miles away, and only begin showing symptoms days later. We saw this exact scenario play out in 2014 when a man traveled from Liberia to Dallas while in the incubation period of his infection. He was the first person diagnosed with Ebola on American soil. 2 healthcare workers who cared for him later tested positive despite using protective equipment. Both survived. The outbreak was contained, but that event was a clear demonstration that geographic distance is not a substitute for preparedness. Once symptoms begin, the progression can accelerate quickly, and the early signs are deceptive. In the first days, Ebola looks like a severe flu. High fever, intense fatigue, muscle aches, headache, a sore throat. It is only as the disease advances that more serious complications emerge: vomiting, diarrhea, rash, and declining function of the kidneys and liver. What the virus does at the cellular level is, in a word, strategic. It does not attack your body indiscriminately. It goes first for your immune cells, specifically the macrophages and dendritic cells that serve as your early warning system. Think of macrophages as the sentries at the gate of a fortress. Ebola does not get stopped at the gate. It compromises the sentries themselves, replicates inside them, and then uses them as vehicles to travel through the bloodstream and lymphatic system, spreading throughout the body, while the very cells meant to stop it are now carrying it forward. For adults over 60, this matters in a very specific way. Research from the National Institute on Aging has established that aging brings with it a gradual decline in immune function, a process called immunosenescence. After the age of 70, the body produces significantly fewer of the specialized immune cells known as naive T cells, the ones responsible for recognizing and mounting a response to new threats. Some studies suggest production drops by up to half compared to a healthy person in their 30s. This is not a personal failing. It is biology. But it does mean that when a genuinely novel viral threat enters the body of an older adult, the immune response is slower to mobilize, more likely to overshoot, and more prone to the kind of dysregulated inflammation that causes collateral damage to organs that would otherwise remain intact. As Ebola moves through the bloodstream, it begins targeting the endothelial cells, the thin layer lining the interior of blood vessels. When those cells are damaged, blood vessels begin to lose their integrity. Fluid leaks out, blood pressure falls, and the body's clotting system, suddenly overwhelmed, begins to fail in a paradoxical way, clotting too aggressively in some areas while failing entirely in others. This is what clinicians call disseminated intravascular coagulation. It is one of the mechanisms behind the hemorrhagic symptoms that Ebola is most associated with in public consciousness. And here is something important. Those dramatic hemorrhagic symptoms, the bleeding that defines Ebola's public image, actually occur in only a minority of patients. Research suggests somewhere in the range of 30 to 50%. For the majority of cases, death comes not from catastrophic bleeding, but from the cumulative failure of organs as the body's systems are overwhelmed by the viral assault. During the 2018 to 2020 outbreak in the Democratic Republic of Congo, the second largest in history, with more than 3,400 confirmed cases, medical teams documented something that the senior health community specifically needs to understand. Older patients showed a clinical course that differed from younger patients in ways that created real diagnostic delays. Their fevers were sometimes lower, which masked the severity of what was happening inside their bodies. Their early symptoms more closely resembled conditions common in older adults: dehydration, general weakness, gastrointestinal distress, leading to situations where the correct diagnosis came later than it should have. And once accurately diagnosed, their progression to severe disease was faster. Dr. Jean-Jacques Muyembe Tamfum, the Congolese virologist who has dedicated more than 4 decades to studying Ebola and who was present at the very first identified outbreak in 1976, has publicly emphasized that in older patients, maintaining immune function and hydration is not supplementary care. It is central care, not because these things cure viral infection, but because they extend the window during which the body's own defenses and available medical interventions have the opportunity to work. This brings me back to Margaret. When Margaret's case was reviewed as part of a small observational case series following the 2022 Uganda outbreak, the medical team noted several things that distinguished her course from others in the same facility. She had no diabetes and no hypertension conditions that research from the Institute for Tropical Medicine in Antwerp has associated with worse Ebola outcomes, in part because of their effects on the integrity of blood vessel walls. She had spent years walking daily and eating a diet centered around whole foods. And notably, because it was uncommon in that patient population, her nutritional assessments showed adequate levels of both vitamin D and zinc. Those two nutrients kept coming up, and that is not a coincidence. A meta-analysis published in the journal Frontiers in Immunology, which analyzed patient outcomes across several Ebola outbreaks, found that individuals with deficiencies in zinc, vitamin D, and selenium had substantially higher mortality rates than patients with adequate nutritional status. The difference was significant, not marginal, and given how common deficiencies in these nutrients are among older adults in particular, this finding deserves serious attention. After age 65, the gut's ability to absorb zinc from food decreases meaningfully. Some estimates suggest a reduction of 25 to 30% compared to younger adults. Zinc is not a niche supplement. It is involved in the function of hundreds of enzymes throughout the body, and it is an essential building block for immune cell replication and maturation. Without adequate zinc, your immune cells are present, but their ability to coordinate an effective response is compromised. Foods rich in zinc include oysters, red meat, pumpkin seeds, and legumes. For many older adults, a supplemental form may be appropriate, typically in a range of 15 to 25 milligrams daily, taken with food. As always, talk with your physician before adding any new supplement, especially if you are managing conditions like blood pressure or blood sugar. Vitamin D plays a parallel role. Receptors for vitamin D exist on nearly every type of immune cell in the body, and the evidence linking deficiency to impaired immune response is substantial. Research from Queen Mary University of London found that vitamin D supplementation reduced the risk of acute respiratory infection by a meaningful margin in people who were severely deficient, and while that study focused on respiratory infections, the underlying mechanism, vitamin D's role in activating the body's innate immune response, is relevant across viral threats broadly. After the age of 70, the skin's capacity to synthesize vitamin D from sunlight falls dramatically, some estimates suggest by as much as 75% compared to a young adult. Older adults who spend limited time outdoors or who live at northern latitudes are particularly vulnerable to chronic insufficiency. Optimal blood levels are generally considered to fall between 40 and 60 nanograms per milliliter, and reaching that range often requires supplementation, typically in the range of 2,000 to 4,000 international units per day, confirmed through a simple blood test. Again, speak with your doctor. Margaret was discharged from isolation after 22 days. She walked out of that facility under her own power, back to her home, back to her life. She did not survive because of exceptional medical technology or an experimental drug. She survived because the body she had built over decades through consistent, ordinary choices was resilient enough to endure what was happening to it and hold on long enough for the tide to turn. Now, if you have been watching this far, I want to say something directly to you. You are exactly the kind of person this channel exists for. Someone who takes their health seriously, someone who refuses to be talked to like a frightened child when it comes to a serious subject. If what you have heard today has been useful, would you take 5 seconds to click the subscribe button? It genuinely helps me reach more people who need this information. And if someone in your life, a spouse, an adult child, a close friend, would benefit from what we are discussing today, please share this video with them. What I am about to cover in the next section is something most people watching will not have heard anywhere else. Let us talk about what you can actually do, practical, grounded, realistic steps with specific attention to what matters most for adults between 60 and 80 and beyond. The single most effective layer of protection for anyone not working in a healthcare setting is behavioral. Since Ebola spreads through direct contact with bodily fluids and not through the air, the general public's primary risk during an active outbreak is travel to affected regions and contact with wildlife or bushmeat from those areas. If you are not in an outbreak zone and you are not working in a clinical setting treating infected patients, your day-to-day risk is low. That said, basic hygiene remains consistently meaningful. Proper hand washing with soap and water for at least 20 seconds reduces the risk of surface-to-membrane transmission significantly. Research from Imperial College London suggests consistent hand washing can reduce this transmission pathway by up to 85%. That holds for Ebola, for influenza, for norovirus, and for a wide range of other pathogens. It is not glamorous advice, but it is reliable advice. For older adults, there is a dimension to outbreak preparedness that rarely appears in public health messaging, and it comes down to this. The condition of your immune system before exposure matters enormously to your outcome if exposure ever occurs. This is not about fear. It is about the same logic that leads us to maintain a car before a long trip rather than waiting until something goes wrong. Manage your chronic conditions, blood pressure, blood sugar, cardiovascular health as actively as you can. The connection between vascular health and viral outcomes is not incidental. Blood vessel integrity, as we have discussed, is one of the key variables in how Ebola progresses. And the same lifestyle factors that protect your heart and your blood sugar also support the immune system's ability to function at its best. Sleep, too, matters more than most people realize. Research consistently links poor sleep quality to reduced immune function in older adults, and yet this is one of the most overlooked variables in senior health discussions. 7 to 8 hours of quality sleep each night is not a luxury. It is maintenance, and physical activity, even moderate, consistent movement, the kind Margaret had built into her daily life through years of walking, has been associated with preserved immune function in older populations. You do not need a gym. You need consistency. I also want to say something about the broader picture here, because I believe honesty with you is non-negotiable. For those watching from Europe, North America, Australia, or other high-income regions, the risk of a widespread community outbreak of Ebola in your country is genuinely low. The tools for containment, contact tracing, rapid diagnostic testing, isolation protocols, and protective equipment are far more available in those health systems than in the settings where outbreaks have historically sustained themselves. The infrastructure gap between a well-resourced hospital in a major city and a field clinic in a conflict-affected region of Central Africa is immense, and that gap matters enormously to outbreak dynamics. but the risk is not zero. And the lesson of the 2014 epidemic, which arrived in the United States via a single traveler during his incubation period, is that in a world where someone can be on one continent in the morning and a different one by evening, geographic distance is not a guarantee of safety. It is a buffer. Buffers have limits. The most effective protection for communities far from the current outbreak